So good afternoon, everyone, and thanks to the entire team, organizing team, for having us here. So over the next 20 minutes to half an hour, we'll just go through, a few insights on what's new, and I think Dr. Santosh has a very nice presentation on robotics, and maybe at the end we can show you one of our robotic hepatectomies to see how things have progressed on that front as well. So there are a lot of myths and misconceptions among the general population, but also among a lot of doctors. And we'll try and dispel a few of that. So most people feel that HPB cancers, liver, pancreas cancers are usually poor prognosis. Many people are told that, you have a liver cancer, this is probably the end of the road for you. So when we look at outcomes of liver resections, we find that liver tumors overall, when operated, have more than a 55 to 60% 5-year survival, and in oncology, 5-year survival is cure. So more than 55 to 60% of patients with liver cancers are cured with surgery, which is much better than a lot of other cancers. Metastatic liver disease, this is another area of focus that we do a lot of work on. Especially when it comes to colorectal liver metastasis or neuroendocrine liver metastasis. Again, this is a common misconception. It is spread to the liver, probably nothing much can be done. When you look at this data, and this is worldwide data of more than 11,000 patients, we look at 5-year survival of more than 40% in metastatic disease, which is exceptional. And in solitary metastasis, we are looking at more than 60%. So the outcomes today are unimaginable as compared to what was, what existed 10 years back. The other myth or misconception is liver surgery overall has a high mortality, or, it's very risky, a lot of blood loss. And it used to happen when we were medical students. But today we have papers like this which say more than 1,000 hepatectomies without any mortality. And that is a reality in our center as well. Cirrhotic livers, that the other misconception is anyone with cirrhosis with a tumor always has to go for a transplant, but we are doing a lot of cirrhotic liver resections, and with a fraction of the cost and with much less morbidity to the patient and to the donor, we are able to send these patients home and safely. Let's look at some of our data over the last decade or so. 730 liver resections and around 650 pancreatic resections, huge range in terms of age. Overall, our mean blood loss in hepatectomies is around 500 ml. Most of these patients, 65% of patients, do not or did not require blood transfusion. Overall, our mortality is less than 1% for hepatectomies. We look at portal clamping, which actually delays liver recovery, so we don't do that in almost 2/3 of patients. Pancreatic resections, again, 70% plus did not require blood transfusions in our Whipples. Morbidity is around 18%, but mortality is around 0.8%. So let's look at some of these tumors and see how, what is so different. HCCs, why is HCC or hepatocellular carcinoma different from other tumors? Is because it arises in the background of cirrhosis. So most tumors, the rest of the organ is normal, but in HCC, the entire liver in 80% of cases is cirrhotic, and that has to be taken into account. These are all the range of treatments that are available, right from liver resections to transplant, to ablations, to TACE and radioembolization and immunotherapy, sorafenib, so a lot of options. So let's look at one of these cases. There's a 60-year-old gentleman who came to us with this large liver tumor, stuck, we couldn't see the middle hepatic vein here, the right hepatic vein was completely involved. So this patient, here we found that the remnant volume of the liver seemed to be a little less. So we thought, so we got our interventional radiologist to do an embolization. So what we do is we block the portal vein on the side that we are going to remove. So preferentially it increases the blood supply to the left side. So we had an increase in the remnant liver volume, and then we went ahead and resected this patient. So today more and more we are having a complex interplay. It's not just one treatment. It is interventional radiology facilitating surgery or surgery facilitating IR, and it's usually multimodality treatment. Small lesions like these are very amenable to non-surgical treatments or minimal access treatments where we can resect them laparoscopically or robotic, or we could also put in a needle and burn these tumors with microwave ablation. And that's something that we do along with our interventional radiologists. Then there are big tumors like these with portal vein thrombosis, which are not amenable to surgery. And these are patients, we still have options for these patients in terms of radioembolization called TARE, and it's an expensive procedure, but it's got some really good results in patients. Sometimes we use TARE to downstage these patients to surgery. Then newer drugs have come up, which are a combination of immunotherapy and targeted therapy, and that's really worked magic in HCCs. So with every passing year, we have newer technologies and newer treatments available, and more of these patients live longer. Then we look at colorectal liver metastasis, a little bit about this. So almost 20% of patients with colorectal cancer will present with liver metastasis when they present to you, and more than 50% will have metastasis in the liver at some point in the future. So what do we do with them? Now, most of them, almost 20% of these, only 15 to 20% of these patients will be resectable upfront, and 85% of them will not be resectable upfront. So the first step is to analyze the scan, the CT scan or the MRI, to see whether they are resectable or not, and to see how, what can we do for them. So that is the first step that we do. And the ones that are not resectable, we give them neoadjuvant chemotherapy. Today we have a huge range of chemotherapy drugs which are available, and we are able to downstage and then resect at least 30 to 40% of them. Not very long ago, in the 85 and 89, not just 20, 30 years back, people used to say that there's no point in treating colorectal liver metastasis. And we fast forward to just 25 years later, we have papers where we look at 10 years survival in colorectal metastasis. So it's a quantum leap. And what has led to this improvement? Today, the biggest, what has really changed this is not the surgeon, but it's the medical oncologist, because they are able to convert patients to surgery by giving newer and newer chemotherapy, newer and newer targeted therapy, and that has actually changed outcomes for a lot of these patients. So patients who respond well to chemo do very well with surgery. There's a lot of refinement and improvements in surgical techniques. We've got much better instrumentation, better equipment. We've got intraoperative ultrasound. Every single patient undergoes an intraoperative ultrasound. We do what is known as sono-guided surgery. So we've got the sono machine in the OT, which helps us guide our cuts, which helps us minimize damage to the rest of the liver. So previously, people used to do big hepatectomies, right extended. Today, for multiple colorectal metastasis, we are doing more and more of these ultrasound-guided surgeries, where we are able to precisely just get that tumor out along with the margin, and we are able to save much more liver. Outcomes are much better. Liver failure is much lesser. So these are all the basic principles of surgery for colorectal metastasis. One of the things that we are always wary of is that we don't give too much of chemo to the patients. Otherwise, the medical oncologist, being encouraged by the responsiveness, sometimes give 8, 10, 12 cycles. And then we have something called disappearing liver metastasis, where on radiology you're not able to make out, but the lesions are actually there, and that's why the recurrence rates are higher. So, it requires a lot of collaboration between the surgical team and the medical oncologist. So we tumor board these patients, and we sit together and plan out, along with the radiologist, along with the surgeon and the medical oncologist, and we plan out usually 3 to 4 cycles, and then we go ahead with surgery. Lesser cycles of chemo means lesser damage to the liver. The outcomes of liver surgery are much better, and more and more we are using MRI as a guide. It's a very, very good tool now. Contrast MRIs are much better sometimes than CTs at picking up these lesions. Then there's something called a liver-first approach. That's very new. It's a lot of papers now, and we've been following this regularly. So I'll just share this small example with you. So this was a young lady who came to us with a very bulky rectal cancer with a single lesion in the liver. Now, traditionally, this patient would have received 3 to 4 cycles of chemotherapy and then gone for chemoradiation and then come up for surgery. here what we did because of the liver first approach is because it was a single small lesion, laparoscopically we resected that lesion up front, and then this patient was like a patient without a metastasis, and hence directly went for neoadjuvant chemoradiation over 6 weeks, and then robotically got resected for an anterior resection. So there are patients like these where you've got bulky rectal cancers along with bulky liver cancers, where we would go the traditional way of chemotherapy first, chemoradiation, and then surgery. Even for bilobar metastasis, where we feel that, traditionally the dictum was that if it's bilobar, you can't treat it. But there are various techniques today. I wouldn't go into the details because it's a very technical discussion. But we've got various options like 2-stage hepatectomies or ALPS, and there are various ways by which these patients can be treated. Then there's minimal access surgery. We do robotic surgeries and laparoscopic surgeries. This is the Da Vinci robot which we have, the Da Vinci Xi, which is the best in class in terms of the worldwide. There's no better robot than this, and that is the one that we have in our OT. And that's enabled us, we do a lot of robotic colorectal, but we also do robotic livers and distal pancreatectomies, and we'll go through that. I'll try and show you a video in some time. Then we look at pancreatic cancers, a little bit about what is new in pancreatic cancers. It's a dismal prognosis tumor. Overall, these are bad tumors, and unfortunately, the long-term outcomes of pancreatic cancer are yet not good. 30-40 years back, mortality was 10%, morbidity was around 40%. Today we've been able to bring down the morbidity and the mortality, but overall, when we look at pancreatic surgery, we're looking at much lesser blood loss, much lesser blood replacement. Operative time hasn't changed much. Surgical related deaths have gone down significantly, reoperation rates have gone down significantly. But when you look at the curves for overall survival, they're pretty much similar 30 years back to now. Now, over the last 5 years, there are some newer chemotherapy agents which have come, some encouragement in terms of long-term outcomes. But overall, this is a cancer that still needs to be conquered. Some things that have improved. So why surgical outcomes improved? So that's because, again, just like liver, we've got much better imaging, much better instrumentation, better anesthesia, intervention radiology. So these are, I'll just skip this. This is a patient who had a portal vein involvement with a pancreatic head cancer, and we routinely do a portal vein resection with a reconstruction. This is a patient who had a very young patient who had a small hepatic artery involvement, and we replaced that with a graft with our vascular surgeon. So technically a lot of things can be done much more safer with better and better transplant experience. I think we're bolder now and with better outcomes. But when as I said, the long-term outcomes will need a lot of better chemotherapy. And the two new regimens which have come up over the last 5 years or so is FOLFIRINOX and Gem/Abraxane, and they've really changed outcomes, and probably in the next 10 years we will see a lot of improved survival. There's a lot of discussion about laparoscopy and robotics in pancreas as well. When it comes to a Whipple's operation, in fact, it's very controversial whether we should be doing minimal access surgery. And, I am a little conservative on this because the outcomes of a Whipple's depends upon the fineness of the anastomosis, and there's still a way to go before, for small ducts. I think the outcomes of minimal access surgery are poorer as compared to open surgery. So, we still advocate open surgery for a Whipple's. But for a distal pancreatectomy, we are very, very comfortable doing minimal access surgery, either laparoscopic or robotic. Then we come to neoadjuvant chemotherapy. Again, it's played a big role in improving outcomes in pancreatic cancer. A lot of studies, a lot of literature on this, and there's a lot of debate on whether to just give chemo or give chemoradiation, but not much to choose between the two regimes. But we do select out patients, for one or the other, depending on various factors. So there's definitely been improvement as far as technical safety is concerned, but long-term outcomes are slow to improve, but probably the next decade will show better outcomes with these 2 new chemotherapy regimes that are available. And we are still waiting for the magic targeted therapy to change, to have a huge drastic change as far as outcomes are concerned in pancreatic cancer. Excuse me. Can you? I'll just try and show you a quick video of a robotic hepatectomy, if we have another 5 minutes. And okay, that's nice. So this was a 76-year-old gentleman, and we did a left lateral hepatectomy for this patient. This is the port placement. How do I fast forward? This one you need to remove. Yeah. So here we are using 2 instruments. Now you can see the kind of magnification that robotics gives. It's 10x. Now what 10x does is that it shows you every single small blood vessel. And that contributes hugely in terms of improved precision and improved, in fact, most studies have shown a significantly lesser blood loss in robotic hepatectomies or in robotic surgery as compared to open surgery, and that's the reason. We just used to see this patient has had 3 cuts of 8 millimeters and 1 cut of 12 millimeters to get the instrumentation in, and that's a robotic harmonic scalpel that we are using. I'm using on my left hand, and the other one is a robotic bipolar. And you can, while you may not be very aware of the technicalities, what it's interesting to see is the precision with which we are able to see tissues, and I think that makes all the difference. So I think as a technology, robotics is really here to stay, and just as it is in orthopedics or in cardiac, as you guys mentioned. And I think the next couple of decades will see us completely changing and transforming the way we operate on these patients. And the other advantage of this instrument or robotics is the wrist movement. So it mimics the human wrist. So you can actually turn around your instruments the way you would move your wrist. And that is the big difference between laparoscopy and robotics. Robotics has got 7 degrees of motion as compared to just 2 degrees of motion in laparoscopy, which again improves your dexterity. It enables you to adjust yourself in spaces which otherwise you would struggle to, which is why in the pelvis it's really beneficial. So for a low anterior resection, for example, we would be very happy to do it. We always do it robotically. So this is just to show, and I wouldn't, I think we can stop that and maybe take a couple of questions if we have time. But I think that was just to show you and highlight what we are doing. And I think it's very exciting, and probably the next decade we'll see much more of this. Thank you.
Thank you, Dr. Nagarajan sir, for such a wonderful presentation. It was really a very nice session, and I request the chairpersons, Dr. Nitin Singh and Dr. Aarti Vyas, to please felicitate our speaker.